Good morning, and welcome everyone to the Baker Institute, those who are joining us in person and those who are watching online. My name is Kenny Evans. I'm a fellow here with the Science and Technology Policy Program, and it's my pleasure to welcome you to the 9th Annual Texas Heart Baker Institute Lecture on Regenerative Medicine. This series is a long-term collaboration that started with the former president of the Texas Heart Institute, the late Jim Willerson, a legendary figure in clinical research and health policy. Over the years, the series, we've covered a number of topics that impact Texans related to stem cells and regenerative medicine, including current research advances in regenerative medicine, the risks associated with unproven stem cell therapies, Texas policies on stem cell research, misinformation, and other ethical issues. These lectures have been generously funded from the beginning from a grant from the George and Mary Josephine Hammond Foundation. I would also like to thank the Baker Institute staff, especially Kaylee Waldrop and Laura Hotze, for their support organizing today's event, as well as my collaborator at the Texas Heart Institute, Carrie Sprung. Today's event, titled Science at Risk, Funding for the Future of Medical Innovation, will highlight two speakers with different perspectives on medical innovation and research. This discussion will focus on the impact of federal funding in clinical trials. In 2025, we have seen a series of changes, I would add dramatic changes, within the federal government regarding funding for medical research. First, DEI, diversity, equity, and inclusion research has been defunded, which is critical for clinical trials to include broad participation from patients to ensure interventions are properly tested and replicated. There have been significant reductions in force for health-related agencies, such as the CDC within the Department of Health and Human Services, that fund and regulate biomedical research. As a result, clinical trials have been put on pause, and regulatory oversight has slowed. There have also been proposals for significant cuts to funding for research and development. These include cuts to what's known as overhead and direct costs, including at research hospitals and universities, as well as cuts to the number of size and of research projects. Texas, and especially Houston within the TMC, is a hub for medical research and innovation. However, Texas has already seen a 30% reduction in federal funding this fiscal year from the National Institutes of Health alone from last year in 2024 levels. In addition, funding for the state and the federal government is lower than one would anticipate compared to other states of relative size, with smaller states outcompeting Texas, including New York, Massachusetts, and Pennsylvania. As we look towards the future, with less staff to oversee regulation and potentially lower funding for clinical research, one has to wonder how that will impact medical innovation and development of new treatment and therapies. So I'm looking forward to today's discussion. Thank you so much for being here. Moderating today's event will be someone who needs no introduction, the Baker Institute Director, Ambassador David Satterfield. Please help me welcome David to the stage.
Thank you, Kenny, and thank you all for being here this morning. This presentation, this discussion, is one of a series of discussions we will be having with notable speakers, discussing issues ranging from this topic, innovation, consequences of cuts real and potential to federal funding, but also a deep dive, as we have done in the past, into specific areas of healthcare. We will have at lunch, noon, on the 9th of this month, Michael Mann and Peter Hotez speaking on the subject both of vaccines, but the assault on science in general. These will be, both those events and others to come during the course of the fall and the spring, I think quite interesting for all of you. I'm honored to moderate this morning's important discussion on medical innovation. From cancer treatments to regenerative medicine therapies, there are so many new, exciting, promising areas of innovation that researchers are working on to revolutionize medicine, which means healthcare, which means addressing the needs of every one of us and our fellows here in the United States and around the world. However, many scientists, physicians, patients, including myself, worry that cuts to federal funding and oversight of medical research will directly impact medical innovation, both now and in the future. To discuss the issue today, we have two speakers to provide different perspectives on medical innovation, Dr. Emerson Perin and Ms. Micaela Alpert. Dr. Emerson Perin is a world-renowned cardiologist who has provided leadership at the Texas Heart Institute for more than 25 years, where he currently serves as director of the Center for Clinical Research and the Stem Cell Center. Dr. Perin is a pioneer in regenerative medicine, clinical research. He performed the first stem cell injection in a patient with heart failure in 2001 and has since led groundbreaking clinical trials advancing therapies for cardiovascular disease. Dr. Perin also serves as Director of Interventional Cardiology at Baylor St. Luke's Medical Center and is recognized internationally for his contributions to advancing innovative treatments for heart disease. Our second speaker, Ms. Micaela Alpert, is a first-year medical student at the Perelman School of Medicine at the University of Pennsylvania. She's a recent graduate of the University of Pennsylvania, where she earned her undergraduate and master's degrees in biochemistry, biophysics, biology, and chemistry. At UPenn, she worked in the Chondros lab, where she focused on genetic regulators of fetal hemoglobin in sickle cell disease and beta thalassemia. Ms. Alpert will draw from her experiences as a patient and a future provider and researcher of medical care to bring a unique perspective on the real-world aspects of research and clinical care. I'm going to ask each presenter to come up one at a time, then both will join me on stage for questions afterwards. If you'd like to submit a question for the Q&A session, please use the QR code seen on the event slide. It will direct you to a Google form where you can submit your questions and identify to whom you wish to direct the question. Feel free to submit multiple queries if you'd like by reusing the link. The link will be posted online for those watching the live webcast. With that, I'd like you to join me in welcoming to the podium Dr. Emerson Perin.
Thank you for that nice introduction. I guess it's kind of a fun talk. I only have 10 slides, and usually I'm talking about regenerative medicine. And before I get into anything, I would just want to tell you in one sentence that I'm pretty sure we will be curing heart failure before I retire. But that's a different topic, maybe next year. But we're making incredible advances that we didn't even know about a year ago. So I'm really going to focus, if we get my first slide up, really focus on federal funding, really. I kind of had fun with putting a title on this. I thought about naming this talk Science and Stupidity, but I thought federal funding, science, and innovation would be a better title. Let me see. Okay, so we're in Houston. So federal funding, on one end, when you have massive projects such as putting a man on the moon, requires a country behind it. I mean, so you do need something like the federal government to put a man on the moon. In today's dollars, it's estimated that the Apollo program probably cost about $320 billion. So, that's not something some company is going to say, oh, let's do some science to get these guys up on the moon. So I feel like in the world today with a lot of misguided people in leadership positions, it's almost, I'm starting from the beginning and I'm putting a very fundamental slide up. So what is science? Science is a systematic method for understanding our natural world, understanding the truths of the natural world. And we gather evidence, we experiment, we come to evidence-based conclusions, we repeat these experiments to make sure that they are true and valid. And this really is what builds a knowledge base in our society and in the world that advances humanity. And innovation and invention are at the core of this. Invention is kind of like something brand new. You invent the light bulb. Innovation is like, you take things and make new things from it, like inventing a smartphone. But science does fuel both invention and innovation. Think about it. Let's think about, physics, flight, propulsion. Oh, okay, I can build an aircraft, and then that leads to development of different tools and airplanes, engines, airports, equipment, things associated with that. There's a whole field that then develops around that. You end up with a worldwide transportation system with airports and untold complication of something. All starts with a few things that then develop, and you need science to understand how things really work, or else, that you get things wrong. And so this kind of provides a fundamental knowledge for society to move forward. Now I'm not going to talk about this, but this is a very complicated slide, but I thought it was kind of cool, because as we get down to the sort of the nitty-gritty of science, so this is a slide that I use to explain why there's a long-term effect of cell therapy when we treat heart failure. So I went on ChatGPT to try to figure out how many articles and papers are behind this one slide that explains this mechanism. And I was pretty surprised. There are easily over 1 million articles behind what's stated in this. Isn't that crazy? Just in IL-6, which is an interleukin, just on that, on one aspect of IL-6, I found 84,000 papers. I mean, it's unbelievable. So it takes a lot of science and a lot of work and a lot of understanding to make progress to get to where we can advance our knowledge. So I wanted to go to something that's very important that you may or may not be aware of, something called the Bayh-Dole Act. This is from 1980, back when the government really was a pretty good guy. This is during the Carter administration. And this was revolutionary and really put the U.S. In front of the world and in the position that we kind of still are now and kind of losing quickly. But this act, it basically allowed universities, academic centers, and nonprofit institutions to be able to maintain ownership of patents and ideas and things they got that were provided with by federal funding. So before 1980, if you had federal funding and you came up with some IP or something, that all belonged to the government. But after this, if you had federal funding and you invent something and you figure something out and you can patent it, all you have to do is you kind of have to tell the powers that be, the government, what you're doing, what you're filing, the patents that you're doing, but that belongs to you. And you can now commercialize this, and this is, if you understand, this is the fabric of our society and of scientific discovery and economic growth at the end of the day, when things like this were done. So this really established how things work. We take this for granted, but actually people thought about this. So you have retained ownership of what you develop and discover with federal funding, and commercialization is encouraged. That increases innovation, it brings economic growth, and at the end of the day, society as a whole benefits from this. So we're just kind of used to this. We don't think about it, but it happens every day. So, I've had many NIH and, federal funds, and we take all this for granted. But this is something important to know about. So I just put this up. This is this cardiovascular network for research, cell therapy research network that was started in 2007. This is the second iteration. And went from 2007 to 2019. And Dr. Wilderson and I had the pleasure of being PIs of this thing. And this is the second iteration. I just put PACE is a trial that would have never been done. Sometimes you need federal funds to do things that companies aren't willing to do, because you're not going to make money straight out of it. You need to figure stuff out before then you go oh, okay, let's do that and do this. So there was no trial of intermittent claudication ever done. We did it. CONCERT-HF was the first trial using 2 different cells together in combination. That's kind of nobody's taken a millions of dollar gamble on something like that. You need the government to back that up. And Seneca was the first trial using women, especially that had cancer and chemotherapy, and using stem cells to treat heart failure induced by chemotherapy in those patients. So this is an example of NIH network with federal funding, doing things that kind of start things off. And as I've kind of given you the background, and then things can then spin off from there, and we advance and new treatments happen. You have amyloidosis now. We got drugs that treat that and make you better. AIDS used to be a death sentence. Now you take a pill and you live your life. Cancer is going very much in the way of AIDS. Used to be like, oh my God, cancer. Now it's like, oh, okay, well, let's do this, do that. There's all these immunotherapies and things. So things are changing thanks to science. I'll end with this because we can have a fun discussion. But I just wanted to, for the non-initiated, many of you may know this, but in a budget of an NIH grant, there's two big buckets. One is direct costs and one is indirect costs. So direct costs are, let's say you get a $100,000 grant. So that $100,000, you got to say, okay, I'm going to do this, that, and the other, and here's the budget, and you account for every penny. I need this reagent, and I'm going to use these cells. I got to make this, and this costs this much, and you itemize everything, and that's my $100,000, and that's direct cost. That's your grant, okay? But there's something called indirect costs, and indirect costs are negotiated by every academic institution with the government. And it's basically the part of the grant, it's the facilities, FNA, Facilities Administration. So you got to keep, let's say the Texas Heart Institute, we have a negotiated indirect cost of 67%, okay? So if I get $100,000, I get $67,000 that goes to the institute. And that keeps the lights on, keeps the machine, the centrifuge working, the maintenance of the stuff that we have, the equipment, things that, the building, the people to clean the laboratories and things like that. So and we don't have to itemize that. And there is some crazy thought on part of some people in the government that these indirect costs are crazy high and that investigators must be taking first-class trips to Europe or something on this money. And so we need to cut these indirect costs. So they proposed to cut the indirect cost of 15%. Okay, I saw Baylor College of Medicine up there. At Baylor College of Medicine, that represents $80 million a year. At Texas Heart, it represents a little less than that because we're a smaller place. But nonetheless, at Baylor, a lot of people were let go. This hasn't been acted out yet, but you can't just sit there like, oh, yeah, we're going to have $80 million less, so let's just keep everybody around. So we, at Texas Heart, we had to get a package, and we had to let a lot of people go. So, as was mentioned, this is already starting because, if you're looking at this future where you're not going to have funds to do things, you have to kind of prepare. You just can't be hit out of the blue by this. So this is sort of a very practical aspect of things that are happening in terms of NIH and federal funding that are affecting in a real way research that we do every day. So this is not some fantasy thing, oh my God, no conspiracy theory. This real dollars. For a while there, NIH wasn't even paying grants that had already been approved. Apparently that's getting better. Okay, so I look forward to a fun discussion. We can talk also about, CDC, FDA, believe me, and all the things that are going on, and look forward to it. So thank you very much.
Ms. Alpert, would you please come up? Thank you.
Okay. Good morning, everyone. I'm very excited to be here today to help share a little bit more about my story as a patient and to give you a look into the patient's perspective and how that kind of integrates into clinical care and research. So, as was already said, I'm a first-year medical student now at Penn. I recently graduated with my BA and my MS degrees, and I did a lot of undergrad research in hematology specifically. But I'm also a childhood cancer survivor, and I'll walk you through a little bit about my journey in the next few slides. Just as a disclaimer, I'm speaking on behalf of myself. I don't represent Penn Medicine, the Perelman School of Medicine, or the University of Pennsylvania. So to tell you a little bit about my journey in 8th grade, this is me when I was in one of my inpatient stays at the Children's Hospital of Philadelphia, which I'll now refer to as CHOP. I received multiple different diagnoses and ultimately found my way down to CHOP. I first had surgery at Penn while I was inpatient and later received chemotherapy. After 4 weeks of chemotherapy, I developed some more back pain and scans revealed that another tumor had grown. So chemotherapy was not working for me. I was immediately hospitalized again and underwent radiation therapy at Penn while I was inpatient at CHOP. Radiation did wonders. I was back to normal for a few weeks until the summer between 8th and 9th grade. And I very quickly found myself in the hospital again. More scans were completed and they found metastases, or basically cancers spreading throughout my body. It was in my lungs, it was in my liver, it was in my abdomen. Now, I had had chemo before, it didn't really work. You can't do surgery on every part of my body, and the same thing with radiation. So I remember very clearly a pretty lengthy conversation between my physicians, my healthcare team, and my parents and me. Now, there were 2 options that my physicians were deciding between. Something called gemcitabine, which is a form of chemotherapy, and this new novel treatment that was relatively new in the US at the time called nivolumab. Now, that's a form of immunotherapy, which I'm sure a lot of you, if not everyone in this room, has heard of. CAR T, I think, is also really big in the news right now, especially at Penn, where they treated the first pediatric patient at CHOP. So, just to get an idea, have any of you heard of Keytruda or Opdivo? I'm seeing some nods. So there was this wonder drug that my doctors told me about. They said it may not work, you may get worse before you get better, because generally with immunotherapies, what can happen is your tumor gets larger before it shrinks, and that is what happened to me. But I remember hearing about this immunotherapy, this new drug, and being very excited and hopeful that this could do something for me, and it did. I'm still on this medication to this day, and it has saved my life. I am in remission. So Opdivo, Keytruda, they're both very similar mechanisms. Keytruda was approved in September of 2014 by the FDA, and Opdivo was approved in December of 2014. Now, I received this treatment in around June of 2017, so a little less than 3 years later. And as I went through my journey and as I received these treatments, I really wanted to develop a better understanding of what was going on in my body and the physiological basis of my disease and the success of the treatment that saved my life. So that brings me to my next step of research. So my first endeavors in research actually were down here at the Texas Heart Institute. For my Make-A-Wish in 8th grade, I chose to shadow a cardiothoracic surgeon at Baylor St. Luke's Medical Center for a week, and I was also introduced and was able to tour the molecular cardiology research labs at Texas Heart. And I came back, after coming down here for the first time in 2018, I came back in 2021, the summer before I started college, to work in the research labs for a few months. And that was kind of the start of my research career. In undergrad, I later joined a lab at the Children's Hospital of Philadelphia, or CHOP, the same place where I received care as a child, working in the Division of Hematology, as was already stated, working on sickle cell disease and beta thalassemia, which led to my master's research. So this is a picture of me in lab earlier, actually a few months ago. And I think what's really important here to emphasize is while I am very much interested in the pathophysiology underlying disease, I also need to remember, especially from my own experience, that everything that we're doing in research and the clinical innovations and kind of the breakthroughs that we're pushing towards, there are people underlying that. There's a face behind kind of every research question. I'll bring that up again later. So I think for me it's very important to pursue being able to pursue a career in clinical care and clinical medicine. I really do want to have hands-on interaction and work with patients and to form that physician-patient relationship and to really emphasize patient-centered care that my own physicians did for me. So in high school, I actually joined my local ambulance agency, and I still ride with them to this day. When I go home for breaks, I'll respond to 911 calls in the back of the ambulance. And I enrolled in an EMT program, became an EMT when I was 16, and then also joined my college agency. So that's a picture of me back in 2021. We don't respond on ambulances, we respond on bikes, but we do the same thing that any ambulance would do. So I think there's kind of two paths, and I really want to integrate those two paths of clinical care and medicine and research together in my future career, because both go hand in hand and both are so critical to patient care and positive patient outcomes. So where does that bring me today? Well, as was already introduced, I'm a medical student now at the Perelman School of Medicine. This is a picture taken from my white coat ceremony a few weeks ago when we first started classes. And moving forward, and I already mentioned this, but moving forward, I really do want to have interaction with patient clinical care and also work on research endeavors. And again, I mentioned before, back in between 9th and 10th grade, I came down to Texas Heart Institute to shadow, and my wish was to become a cardiothoracic surgeon for a week. So that's me at my white coat ceremony, and that is me back in 2019 when I got my first white coat back at THI and Baylor St. Luke's. So again, I want to go back to this point that really hits home for me. There's a human face behind every research question. I think especially as someone, I triple majored in STEM fields back in college, and I think it was really important for me to be able to take a step back and remember that, why are we doing this? Why am I studying the biochemistry that makes up a person? Because it's very easy to get lost in the nitty-gritty details of water and ion channels and all of these things and neurons that somehow come together to form a human. But I think remembering that there is humanity in medicine is so incredibly important. And I was also an anthropology minor in undergrad with a focus on medical anthropology. So I think that when it comes to funding research and when it comes to funding things that impact clinical innovation, we need to really remember that there are patients underlying this, and I don't think this can be overstated enough, even though it seems like kind of a trivial concept to think about. So where are we going in the future? So I think medicine right now is at a crossroads, right? We are seeing an explosion of opportunity. We're seeing, genome editing, personalized medicine, and there are so many opportunities and so many ways to go forward from here. So some things that I think about and that I'm a little worried about moving forward are any delays in advancing discoveries from the bench to the bedside. Science takes a long time right now. To have a discovery, to form a discovery, and to bring that to a patient's side can take years, if not decades. And I'm not saying that this process should be, sped up to compromise safety, but I think that, a lack of funding is going to, for example, shut down clinical research opportunities that patients, may rely on for treatments and cures. So, just like I mentioned, restricted access to clinical trials due to budget constraints may affect, access to cures, treatments that are considered, the last resort, or really a cure for an incurable or possibly fatal disease. The other thing to think about too is insurance coverage for some of these medications. So there are some committees called, I think they're pharmacy and therapeutic committees that review research and review policies to help kind of make formularies, which are essentially a list of medications or therapeutics that are covered by insurance companies. And a lot of that decision making into what goes into what is covered can also include research outcomes from studying these therapeutics or medications. And if we don't have those data, there are a lot of things that go into an insurance company or plan's decision to cover something, but research, I would say, is definitely an important aspect of that. I think we'll also see an increased prevalence of preventable diseases. And I'm not just talking about, vaccines, but also I think there's funding right now for example, screening programs where you can screen for things like HIV and AIDS, or help community-based initiatives for maternal child health. So I think when it comes to funding, this is also something that I think about. And I think, we're already seeing a lot of health inequities as is. I think that reduced funding is also, has the impact to exacerbate some of these things. I think one thing that really stood out to me in my undergrad education is that there are so many barriers to healthcare right now, right? There's what you might think of as sociocultural or socioeconomic barriers. There's cultural linguistic barriers. We're already seeing too that like your zip code, where you live, can matter sometimes more than your genetic code. We've seen that patients who maybe are starting in one location and maybe move to another location that has, potentially starting in one location and moving to another, where we're seeing more common comorbidities or diseases, may eventually develop those later on. So I think right now we're at a very critical moment where a lot of these things can affect patient outcomes and also the outcomes of communities around the nation. And with that, I look forward to discussion ahead.
Thank you very much. If I could invite both of you to come up, please. Micaela, why don't you sit here?
Thank you.
This has been a professional presentation on both your parts, with carefully chosen words and phrasing regarding sets of concerns that each of you have in your life, in your work, regarding the impact of perhaps greater in scale, but not wholly unusual, looks at budgets and funding. But that's only part of the issues with which you, your colleagues, all of us in this room, our friends and neighbors are grappling right now, which is in fact a fundamental assault for reasons either of opportunism, political or economic, or genuine misguided beliefs, quackery, fraud, conspiratorialists, and just plain old grifting on science itself. From individuals who, were they to be subject to any of the medical conditions which their own cuts or quackery would affect, would of course have immediate access to the finest care in the world. So there's hypocrisy blended in with all of this. This is a very unusual environment. It is sui generis. Bits and pieces of it have appeared throughout the history of medical care, going back for centuries. Fraud has always been present, quackery has been present, assaults on scientific method have been present, but not to the extent that we see today, backed by the highest authorities and unchecked by other high authorities. So, in this not entirely encouraging environment, where do citizens, where do professionals, current, aspiring, go? What are, in fact, the long-term impacts of changes which we read about literally every morning, every evening, something new about CDC or FDA or NIH or NSF, all of the alphabet soup of funding mechanisms, regulatory mechanisms that shape our healthcare network? Where, in fact, are we going? Can we manage this if it is only a 3 or 4 year phenomenon? Or is this going to be something with a much longer toll in terms of damage? And Dr. Perin, I'll turn, these are profound questions which I know all of you grapple with, as do we, but what are your thoughts?
Yeah, I can give you a practical example of a trial that we were performing. It was an NIH-funded trial called CONCERT-HF, and it involved 7 centers across the country. And there was, and this was before some of these things, even happen. But let's say at the NIH there was a faction of basic scientists that felt that the clinical science shouldn't be done until we had everything figured out on the basic end. And so there's some person published article in the Washington Post and this has happened. When people say you're doing wrong things, that's a good thing. That means, because if everybody's agreeing, something's wrong. So it's good to have some controversy. But there was an article in the Washington Post, and basically, unfortunately, it influenced the NIH leadership to put a pause on this trial. There's a certain inertia related to a big trial. And if you stop a trial like this, it's kind of like stopping a train, when they push the thing. And to get it going again, I'll just cut the story short. We were unable to finish this trial. Even after the NIH recognized, oh, you know what? We were wrong. You're right. We had to prove to them that the science was perfectly correct. Everything was fine. But at the end of the day, because of the way things worked out, we weren't able to get the number of patients that we needed. And we had stopped at about 120 patients. We needed close to 200. And with the 120, you power a study to give you an answer depending on what the variables you're looking at are. And so we basically had to stop here, and the study was underpowered to show what we needed to show. And if we had more patients in the study, there was a much better chance that it would show. We'd really be more rigorous in being able to get to the answer to our question. So that just didn't happen. So when you stop research, and so now we're in a phase where it's not even about stopping that's happening too, but stopping ongoing trials. But if you don't even start doing things and you go like, well, we're not going to be able, we don't have money to do this. Oh, we're not going to be able to do that. Well, that just has an incredible impact. And, to your question, I don't have the answers. I don't know if it's recoverable. The U.S., if you look at the world, there's an organization that looks at innovation around the world. And the U.S., before, World War II and all these, Europe was the center of innovation. And the U.S. is now, has been the center of innovation. But if you pick up a magazine now, Cell, page through a Cell, and what are you going to find? You're going to find that all the articles are written by Chinese. Not that they do good science. They used to be kind of like iffy, but now, there's really good scientists there. All these Chinese articles. So I don't know what's going to happen, but certainly the focus of where innovation happens may be shifting. And this may be the end of an era where the U.S. really has led innovation for a long time. We'll do everything possible and impossible to we're on a mission, all of us, to advance science and do the things we need to do and push as hard as we can and do everything known to man. But some things are greater than. So I don't know, to answer your question, I don't know in what direction we're heading, but it may be an irrecoverable problem.
Before I turn to you, Micaela, I have a follow-up. In Texas, we have major state-funded innovative medical programs. CPRIT, the new DPRIT, whose funding will go to the voters this November. To what extent can states compensate for the loss of or changes in federal funding in your world?
The state of Texas has been very helpful and very kind to the Texas Heart Institute. Dr. Jim Willerson, who was my mentor and the founder of this section, he had an incredible relationship with the Texas Congress. And I can't tell you the number of times that I needed to do some animal study, a pig study or something, to figure one aspect out of something that we now do in humans. And Jim would say, here's $500,000 that I got from the state legislature. Here, go ahead and do your study. So the state has been very, very kind to us, and I thank the state for that. And so, yes, it's extremely helpful. Now, proportionally, the country and the state of Texas, like my example, can't send a man to the moon. And so the numbers are much bigger when you go federally. And there are certain things that you need more money, you need collaboration, you need interaction, and you need intelligent coordination to make science go forward. And the governmental agencies, the FDA, the CDC, the NIH, and other, American Heart Association, other things, are all part of this world that we have been used to living in and interacting in, to be able to get that economic power to pursue our scientific answers. And so now this is all walking on eggshells, basically.
Because you're at the start of your career. What's it like looking at, reading about all of this from your role, what you have been doing, what you are doing now as a medical student, what you hope to do? What's the atmosphere? What's the impression amongst your colleagues?
Yeah. I think that's a big question that's honestly come up among my peers, the faculty, our mentors. I think that, one of the things going forward that's really scary is, well, I'll kind of backtrack. I want to start with my undergrad experience and the peers and the friends that I made in undergrad. I think a lot of them, I was in an academic program that really emphasized the physical sciences, bench research. And one of the things that I'm noticing now is a lot of my peers who are interested in pursuing medical careers or graduate school and research careers are honestly unable to find work. Some of them were doing longitudinal work in their lab and had plans to keep pursuing their position as a lab tech or a lab manager after graduation, and that's now no longer a viable option. I think when we think about training the next generation of providers, of healthcare professionals, one big thing that comes to mind when we talk about funding is not necessarily just research funding, but also funding to be able to access medical education. So things like grants from the Department of Education and loans to be able to attend medical school. Medical school is very expensive, as I'm sure a lot of you probably know. And we're seeing, so in 2024, the Association of American Medical Colleges conducts a lot of analyses and submits reports on a lot of various different components of medical education. And one of those is, of course, debt of graduates. And back in October of 2024, they released a report that said 70%, around 71% of graduates of medical education programs, specifically medical schools, so people aspiring to be physicians, graduate with debt. And that mean debt is around $205,000. From my own personal experience, what I can say is there are two kind of big buckets of loans that medical students can take out right now. The first is the direct unsubsidized loan from the Department of Education, and the other one is a Grad Plus loan, which kind of builds on top of the unsubsidized loan that's available. So right now, it's dependent, how much you can take out is dependent on your cost of attendance and how many months you're enrolled in school. And one of the things is for the direct unsubsidized loan, you can take out probably, for me, it's like a max of around $47,000, $48,000. Now, tuition is a lot more expensive than that. Housing is expensive, food, transportation, all of that is expensive. So a lot of students rely on that additional Graduate Plus loan bin to be able to pull from for loans to be able to attend school. And that this year was the last year that is available. With recent legislation passed, we're seeing kind of a phase out of the Grad Plus loans, and with a kind of a lifetime cap now for professional school of $200,000. Now, if you go back to what I said before, the the median debt that people graduate with from medical school is around $205,000. So that's already over the kind of lifetime cap for professional students. And so one thing that kind of is really concerning moving forward is the ability to be able to attend school and be able to access medical education. And we're already seeing a physician shortage. We're also seeing a strained healthcare system, and I worry that that is going to kind of add on top of what we're already seeing in the US healthcare system today. And kind of what goes along with that too is also, residency programs that are made available. So residency programs are, being able to take on a resident, train them, and have them provide care is also a cost to the hospital too, and to the healthcare, the academic center. And a lot of that cost is actually offset by Medicare. And with cuts to what we're seeing in Medicare and funding, there may be limited residency positions open. So for those of you who don't know, you go to medical school, you become a doctor, and then there's a period of training that you need to complete before you can kind of practice on your own or become an attending. And if we see those residency positions cut, what that's going to mean is likely fewer positions available in medical schools around the country, again, decreasing the ability to access medical education and to become a physician. And all of those together are likely going to lead to, again, a physician shortage and decreased staffing. And on top of that, we build in, a lack of access to care and preventative care, which will likely increase patient load. And so we're seeing an increase in patient load while we're also seeing a decrease in the number of physicians and other healthcare staff, which is going to, of course, place strain on the healthcare system. And I worry about, my own patients in the future and having them be able to access adequate care. And actually, one thing I do want to jump to too is also the productivity that physicians are kind of expected to have nowadays, right? In clinics, sometimes you'll see a doctor for maybe 15, 20 minutes, maybe they have to rush to another patient, and we're already seeing that today. So, kind of thinking about what are the implications of that in the future? If I end up, working in outpatient and I'm seeing, 30, 40 patients a day, what is that going to mean for the care that I'm able to provide and the care that my patients are going to be able to access? So I think there's this duality of concern for patients and also, of course, concern for research advancements and clinical innovation.
The so-called MAHA, Make America Healthy Again, and I'm reluctant to even dignify this from the podium, but it's real, it's having an impact. Elements of it, diet, processed foods, are, I think, an area where there's broad professional health care agreement that there are consequences of an over-reliance on heavily processed foods. But is there a way to separate the legitimate, positive aspects of this phenomenon, MAHA, from those elements which are, as I said, either quackery, grifting, or combinations of the above?
Well, I think it comes down to leadership at the end of the day. And so, COVID threw a wrench into a lot of things. And let's talk about the CDC for a second. The CDC is not perfect. They did a lot of wrong things. And they could have done a much better job during COVID. For example, did 2-year-olds need to be masked? That's ridiculous, So there are certain mandates and things that were just wrong. So it's not, like, the CDC is not perfect. So there are things like, yes, ultra-processed foods, let's eat better, let's understand nutrition. Maybe there's some things wrong with the CDC and how they do things. It's not all wrong. There's a bunch of smart people there, many of which, are gone. And the same thing with the NIH. Maybe the processes, and the NIH has changed some, but how they select grants and have these working groups and it's extremely competitive, and maybe we could do a better job. So is there room for improvement? Absolutely. And I think aspirationally, we could shake things up a bit and make things better and more efficient. But it's just how you go about doing those things. And I think that's where there's a disconnect in which leadership is very important and sets the tone for how and thoughtfully things. I think the thoughtfulness of how you go about doing things is very important, and I'm not sure that things are being done very thoughtfully in many of these areas. I mean, not very long ago, apparently Florida no longer requires children to be, I'm not even sure I could believe that they're vaccinated. So there's some things that are just like even hard to even believe that are happening. And that all, the buck, in my department, when I do stuff, the buck stops with me. In my little world, I make sure we're responsible and ethical and do the right things. But in a bigger arena, the leadership needs to, the buck stops with them, and the leadership really needs to lead in a thoughtful way. And I'm not sure we're seeing a lot of that.
Micaela, you're going to be one of the science and healthcare leaders of the future. My generation grew up on polio, measles as a killer, rubella, the older diseases, rheumatic fever, scarlet fever. Everyone knew about them. Everyone had members of their family or friends you went to school with, children in braces from infantile paralysis. Iron lungs were a feature of television drama. Everyone remembers this. And the extraordinary progress made, enforced by, nationally, the Public Health Service, uniform Public Health Service members, using census documents to require immunization, the shots at first and then the sugar cube for polio. This was extraordinary. It was a moonshot in the healthcare field, one of the greatest sets of advances, the treatment of historic disease in American history. And it was a success, and it worked. Then came COVID, which led challenges to everything, to experts and to expertise in the generic. From your perspective, at your age, in your professional career, do you see this interruption that COVID created? Is this something you and your colleagues, your mentors, talk about?
Yes, yeah, absolutely. I think one of the big things with COVID is that we really saw, some of the existing inequities and issues with the healthcare system as a whole were really very much exacerbated during the COVID pandemic. One of them being, of course, access to care. We're seeing, for example, in rural communities and populations that are underinsured and underserved, really not being able to access the care that was needed at the time, and that is still needed now. And honestly, it's been 5 years, pandemics may be over, but we're not there yet. We're not seeing the long-term effects of people who got COVID in 2020, maybe 2021, maybe even still now. What are those long-term effects? What are the comorbidities and the manifestations in the long term of having this illness and disease? And we don't really know. And that's one thing that kind of very much worries us moving forward. One of my peers at school honestly says sometimes that it's like the COVID pandemic that lasted, that's going to last 30, 40 years because of what we're going to see down the road. So that's absolutely something that's discussed a lot, and I think that kind of moving forward, what we really need to emphasize is being able to kind of break down some of those barriers in accessing care. And again, I mentioned before when I was speaking earlier about socioeconomic barriers, cultural linguistic barriers, your zip code. Are you able to access the nutrition that you need? Are you able to access the healthcare you need? Are you insured? And all of these things have a big impact on someone's health outcomes. And it's not just the medicine and the treatment that you get. And I think, one way to possibly approach this is kind of moving health out of the clinic and working on community-based initiatives of, for example, something like community paramedicine, where EMTs, paramedics, under a very strict, medical oversight, can proactively go out to the community and screen patients in their homes, help with medication access and things of that sort. And I think that, when we see initiatives like these, we can also help to enhance preventative care and preventative medicine, which I think is not something that has historically been emphasized in the US healthcare system. I think it's a lot of time it's always been, there is a disease, there is an illness, how do we treat it? And that is also something that kind of a lot of times will drive industry and drive, the desire to find a solution to this problem. But what about being able to stop the problem before it starts? So I think that when we think about the COVID pandemic, all of these things, come to mind and are things that we think about as we move forward into the future and kind of expect to see some of the long-term effects of this.
As you look, both of you, at the future, I want to focus in on STEM, cellular-based, genetic-based treatments. You talked about the problem of restarting the train when clinical trials are stopped, when research is stopped. You can't just pick up exactly where you left after 3 years, 4 years, 5 years and begin again. You may not be able to start again at all. How do you generate, at the level of the public, an understanding of what it is you're doing, why interruption can be literally fatal to clinical research, and why it is essential to sustain the funding in the face of budget cuts more broadly, in the face of economic downturns potentially? How do you educate? Not each other, but the public. What can be done that hasn't been done? And I go back to COVID and CDC as a model of a failure to communicate, to quote the famous line.
Well, we live in a world that's very different than it used to be, that has social media in it. And before, if you had an idiot in each village, well, they were kind of isolated, but if you put all the idiots together on a platform, now it sounds like there's this an important force that has some truth that they're, and things that are written down, they seem to be like more, if you write something, it looks like it's true, So the reality of social media is here to stay. And that's really transformed society. And so I guess we really need to understand how we can harness that. You kind of do the same thing in the opposite. You harness the power, just like it's being harnessed by other people for the good, and push your agenda that way. And I will make one point, that one bright spot in all this is there is industry, okay? And we live in a capitalistic society, and industry does fund research. In a way, I'm lucky in a sense that many of the things that I'm currently doing have gotten to a point where industry now is funding research. So that research is going on, thank God, that research is going on. And so the industry-funded research is unaltered pretty much, but that's why I made the point of the slide with all the mechanisms of, yes, this is moving forward, but it kind of like the new fuel that needs to go into the fire to keep everything burning. When you run out of that, we run into a big problem. So, yes, industry-funded research is very important and it's fundamental. On the other hand, and this is in a parentheses, it could be discussed, but it needs to be regulated, because also if industry wants to make money, they may not always have the best interest of patients and society. They want to make money. Okay, so we need to, here the FDA steps in. We need to regulate this, and there's been a lot of things happening lately at the FDA, which is kind of crazy. And so you need smart scientifically based people, like, for example, Vinay Prasad, although he's very controversial, he's very brash, but he's a brilliant physician and scientist. And so you need regulation on top of industry so it doesn't go unbridled. So this is all pretty complex, and at the same time we're kind of losing some of our federal things that used to happen that seem to be going away or decreasing in a significant way. So we're in a hell of a time right now. It's very difficult.
Micaela, is this being talked about in medical school?
Yes, yeah, absolutely. And even before medical school and undergrad, I think it was something that was emphasized, and actually spent several class periods talking about it too. I would say that, kind of to build off Dr. Perin's point, that there's an explosion of how we access data right now, and there's so many articles, so much data out there, and it can be easy to get caught up in the weeds sometimes and see a lot of sources of data, maybe some misinformation, and really not know what to do with that, especially without having a scientific background. And I think to build off of your point, that social media, just as it can provide a lot of that information, is also another way to access and to kind of help enhance a little bit of health literacy and health education. I think kind of on top of that too, another thing that we've talked about is being able to access research and the availability of research. Have you ever hit well, I don't know how many of you are in kind of the science world or regularly read articles, but there are paywalls online when you try to read something. And fortunately, at Penn, at Rice, any major academic institution, you very likely are able to access those through a institution subscription. But it's very easy to, if I go home and I don't have my VPN connected, I hit a paywall, and I can see this really interesting article in the abstract, and I can't see data, and I don't know what's there, and I have to pay something like $8, $10, $15 to read it. And I think that, that can also really impede advancement and clinical innovation. And I think there was one thing actually in undergrad that we talked about. It was a very ironic image of an article that talks about paywalls, but you have to pay for it to see it. And you can look that up when you get back. But I think that was, that really drives the point home. And I think when we talk about being able to really promote health empowerment through health literacy and health education, we need to be able to offer that information freely so that, people can collaborate and people are able to really read it and process that on their own. So that's, yes, absolutely discussed.
On this line, the role of AI. Mm-hmm. How do each of you look at AI, not today necessarily, but over the next decade, as supplanting, replacing some of the role of research now funded by, or that was funded by NSF, NIH, other institutions? Is that even an appropriate question to ask? And I'll start with you.
Yeah, I think the topic of AI is a big one. This is, again, discussed very often when I'm at school and also in undergrad. I think that the use of AI needs to be moderated, but it can be very beneficial in certain senses. So I'll give you an example. There's something called AlphaFold. I don't know if any of you are familiar with it, but it's a way you can plug in, so in your body there are lots of proteins, and your proteins kind of make up your cells and help cells with their function. So there are different ways in which a protein folds, for example, and when it folds, it can become this mature protein that will function the way it's supposed to. And we see sometimes we'll see diseases, for example, in the way a protein folds with a certain mutation in a gene that later encodes the protein, affecting that. And things like AlphaFold, for example, you can plug in a protein sequence, and based off of what we know about the chemistry of that specific sequence, it will predict a folding pattern. And things like that can be very beneficial when we talk about research relating to proteins, for example. The other thing that I'll say too is I'm sure a lot of people, if not everyone in this room, has heard of ChatGPT, if not used it. There is something else, especially for the medical community, called open evidence. And they have they're partnering with JAMA, the Journal of the American Medical Association, and the New England Journal of Medicine to provide medical and healthcare specific to be able to answer queries on kind of their platform. It's like ChatGPT, but basically for medicine and healthcare. And, you know, I don't know if any of you have used ChatGPT, but in undergrad, it was very common where my peers and I would maybe like start with ChatGPT for basic research, just say, hey, what research is out there? What kind of ideas or theories are there? And it'll give you a bunch of data and then say, these are the sources that I pulled it from. And then you go to look up the source and it doesn't exist. And that's very common. I think open evidence, fortunately, will link the sources and you can access them on PubMed, which is a big source of where a lot of healthcare and science journals come from. And that, you know, using it in that way of being able to kind of start at a starting point and then really link to the article and then go down kind of maybe a rabbit hole on PubMed and really look through and synthesize the data, I think is the way to go. So the use of AI needs to be, you need to be very careful about how you use it, but I think as AI moves forward, I think it can be very useful if used in the right way.
AI's been around for a long time. Do you guys remember when Watson won Jeopardy? Because that was a long time ago, right? Actually, back then, Dr. Willerson and I went to IBM, and we said, we want Watson or something like that to read all the literature, and so we can ask it questions. And at the time, IBM wanted $400,000, which we did not have. And we were talking to, I was talking to some computer engineers that are like, I felt like I was an idiot talking to these guys. Anyway, but I get very excited with this because we use AI. So we use AI every day, okay? Every echocardiogram that we do in our office has AI in it to read. So AI is in use. And actually I have this awesome research project with this company in France, the Dassault. They make jets and stuff, but and what we're trying to do is create what we call a digital twin of where you create, like we have a pig and you experiment and you inject and you do an experiment on a large animal. We need to do that because when you do it to people, we need to know it's a kind of a dress rehearsal for doing things, translational medicine, to take new things to people. And so the idea is to create the digital animal model where we input all this data, it learns everything, and it learns how things react, and it's very complex. And the FDA has agreed to accept this kind of data in the future, where then you can experiment instead of having to do a clinical trial in 1,000 people. You might be able to do it without the people on digital subjects. But this is all happening. It's incredible. I think AI it's not, it's in the wrong hands, it could be bad. But I mean, it's a fantastic thing. It will help us, and we're just exponentially going to be able to advance knowledge. We just can't have these bumps in the road like we're having now, which is the reason for our discussion here. It's like, man, we got things to do. There's so many things to be done and discovered, and my to-do list is full. And now we have to kind of go like, we just fired half a department and we don't have the people to do this. And we don't have this. And we don't have money to do this. So this is kind of where we're super excited. We're in an incredible era. The U.S. leads innovation. And we're kind of like in this ununderstandable moment in time that hopefully we'll get over.
Where are the people who are being fired or riffed or who have lost all of their funding? What are they doing and where are they going? Industry, overseas, what's happening?
Or you get a different job. I mean, you can go work at McDonald's. I mean, I'm exaggerating, but people have families, and this is a real problem. I know people that have lost their jobs, and are looking for jobs. And at THI, we're able to give them packages that are going to the end of the year. So actually, in real time here, I have people that I know that are getting money, their salary paid till like December, that have been there for a long time. So hopefully they'll be able to get them. But this is reality. This is happening right now. And these are fantastic scientists that do things that are incredible and that have a unique set of knowledge that we just can't afford to have, which is crazy. And I think the motivation behind this in part is like, oh, that money's being abused, and like I mentioned the first class. Whoever even thought of that is completely out of control. We have ethical guidelines. If we travel, every penny is looked at. So we're extremely responsible with the money that we have when we talk about indirect costs. There's nobody abusing indirect costs. We need that money to do what we do. And we are serious. And if people don't believe that we're serious, we have a problem in this country.
And yet, Micaela, you're committing your life to this career, which is not just medicine, but research. You, your colleagues, what's the motivation?
Yeah. I think that's always the big question is why do we do this? We don't go into medicine and research because it's easy. I think that's something that's been said to me to try and dissuade me a few times from going into the path that I am. But I think for me personally, it really comes down to my own experiences as a patient, and also the friends I met along the way in the hospital, and also through programming for patients like me. I think the healthcare system, as now and previously, there are always changes that can be made to help improve health outcomes, improve access to care, and kind of make it a better system and better world for communities, for individuals, and for the nation. And I think that's a big motivator here, is really that, at least for me, the immunotherapy that was developed, probably took years. It took funding to develop, and it saved my life. And I'm able to be here today. I'm able to go to medical school and to go back to the institution that saved my life, to train now as a doctor alongside my own oncologists, to be able to shadow them, to work on research projects with them, because of the true impact that it has on patients. And it's going to be hard. It will always be hard. And this is definitely a bump in the road, maybe a little bit more than that. But if we don't keep moving forward and pushing to make change, then who will, and when will that happen?
What's happening overseas to your counterparts and colleagues? Are they facing similar challenges from their sources of funding?
They all look on, so we have a worldwide community of researchers in certain fields. We kind of all know each other. The European guys they're a little incredulous of what happens here, and they're pulling for us, and they can't believe what's going on in the U.S. in certain areas. And no, they're not. They don't have the problems that we do. In general, I would say it's a broad statement, but I think the situation here is a little bit more eye-opening, and it's certainly eye-opening to people abroad. And other countries, like I said, may be able to benefit from this, because if we lose our ability to be able to push the envelope and have the investment that we need to have to get to where we need to go, there are other countries that are willing to do that, and they'll take our spot. And it's kind of if you study history, things kind of go in cycles.
We do here at the Institute a deep dive into China, Chinese tech, Chinese educational systems, and the shock, because it was a shock, of DeepSeek, the Chinese ChatGPT AI program. The realization, which came at all levels of government and many levels, I think, professionally, that China was no longer a great fourth-generation producer It was a fifth generation and beyond innovator with massive investment at local level, provincial and city and national level in engineers, people with applied material and process adjectives applied to whatever their professional background was. China is a major cutting-edge competitor, and you've referenced the number of articles as you flip through one publication. We see that everywhere. It's education at the end. So I will bring the conversation to a close by asking both of you, what fundamental changes, if you could wave a magic wand in the U.S. educational program, and I realize introducing trigonometry to pre-K is probably about 3 years away because that will fix everything. But what would you do? And I'll start with you, Micaela.
Yeah.
You're closer to all of this than any of us are.
Yeah, thank you for that question. I think right now I'm very early in my medical education, but I think some of the changes, we're already seeing some of the changes that are being implemented in medical education, medical training. I think one of the things being, I'll just, at the very start, when you submit your medical school application, you're invited for an interview, and at those interviews, you didn't have a traditional interview. Who are you? Tell me about yourself. Why medicine? And we're seeing that medical schools are, sometimes asking now, how much do you know about the healthcare system? Do you know how you're getting paid? I received care from an institution once, and I had an issue with billing, and I later called up the institution. They said, talk to your physician. And I called my physician, and he said, just out of curiosity, how much were you charged for this appointment? And it was in the tens of thousands. So I think, starting with being able to implement in medical education now things besides the basic sciences, and things besides, of course, you have your core, what we call clerkships, your clinical rotations, also, social history, things of that sort, and an integrated research path too. So now a lot of institutions too are also requiring some kind of academic research endeavor or an in-depth research project. And I think as as we move forward, I guess those are some things that I would point to.
Well, that's a very difficult question. Well, actually today, Friday morning, is our first day of interviews for cardiology fellowship at Texas Heart. I'm missing it. It's crazy. We have 600 people apply. We select 80 interviews, and we pick 6 people. So we have really great. Our fellows are unbelievable. It's really hard to ask them these questions, but you can identify, I was just thinking of this, people that want to do research, either you have it or you don't. It's like a fire in your belly. You're born with it, and you can tell. So we don't really have to select out very much for that. But back to the how do we? I think we have to go back to the fundamentals. It's like fixing basketball. Maybe we're not doing that. Let's go back to the fundamentals of being good people, of parents putting good children with the right values in the world. And if we start there, then things follow along as they should. And education and the importance of science and the importance of these things will naturally occur. But I really think it's about maybe fundamentally getting our society on track and back to the original good values that we had.
Many in this audience have heard me talk to this point before, but you've just given me the opening. There was a time not all that long ago where across socioeconomic or demographic strata or categories, you go into a home and there'd be popular science, popular mechanics. Scientific American was viewed as a popular in the true sense of popular magazine. Not every article, but lots. People were interested in science, in nature, in how things worked, the bases of engineering. In a practical sense, it was fascinating. And programming on television, to an extent, I don't exaggerate, reflected this. Has science moved on to become so complex, so esoteric, that the popular dimension has been lost? I ask that to both of you.
Well, I think an interesting thought experiment is this. If there, if there were no more births in the world, okay, you stop all children being born. In 100 years, we'll have an empty planet. That's it, gone, done. Thank you very much. Thanks for playing. Isn't that crazy to think that? I'm sorry. That was a segue into your question.
The character of science today.
Oh, yes.
Is there still a way to cultivate a popular interest in?
Yeah. People used to build. That's one of my hobbies, is to build amplifiers and electronics and stuff. People used to have kits, and we used to build stuff. That in the 60s, that was
Lafayette
super common.
Electronics, yeah.
Yeah, and
Pre-Radio Shack.
It's a different world. Knowledge is acquired in a different way. It requires a totally different skill set. I think, it's good to remember the good old days of maybe how things, but things are different. We need to adapt. We need to change how we think about how we're even going to approach these new challenges. I'm not sure I have the answers. I think, yes, could we change I think we're taking a sidestep in society right now, and I think if we can get back on track using AI, modern resources, social media, all these things that are different now, that really turbo and firepower society in a way that we've never seen before in the direction of good. I think it's doable. I'm an optimistic kind of person. So,
Optimistic note.
Yes.
Last comment.
I feel the same way. I think that I'll go back to what I said before. I think that there are lots of new ways that we get information, and I've been to the doctor's office before. I've seen, like all of the magazines there. And when I was younger, a lot of people had grabbed them, were using them, but now everyone's on their phones, on their tablets, their computers. And there are so many ways to get information that it's often overwhelming. So why, if I could put something into chat, get it to summarize something for me, then why am I spending 3 hours reading the same thing when I can have a summarized version? I think that's what kind of in the direction we're moving in. So I'm not saying we need to kind of retract from that and go back to the way we were, but we need to be able to keep up with these demands now of meeting people where they are in the way they get information. So I think just keep it short. We'll keep it there.
Great. Thank you both. I'm happy that we ended on a more positive than negative note. You have both done and are doing extraordinary things for the benefit of this community, the U.S., the world. We hope that continues. We hope it's recognized and appropriately supported. Bumps along the road notwithstanding. Thank you both, and thank all of you.